Hi, this is Nicole Newton, RNA at the University of Tulsa, and welcome to our Induction to Intubation lecture. We will cover the entire induction process from the time the patient comes into the OR to the final sweep after intubation. The objectives of this presentation are to identify anesthesia and safety equipment needed for the induction process, identify the steps of pre-induction, induction, intubation, anesthesia machine adjustments, and immediate post-induction, and to identify steps and importance of room and patient sweeps. So you have already done your machine check in the morning. Now you're preparing for your case. You want to make sure you have everything you need to protect yourself and the patient during the case. This includes your scrub cap, gloves, and making sure that you do your hand hygiene, your mask, which a majority of cases you'll only need a regular surgical mask. However, for some cases you'll need an N95. You'll want to make sure that you have eye protection, whether this is goggles or a face shield. In some cases, they'll have body fluids flying over the drapes, even if they're really high, so you want to make sure that you're always wearing some form of protection. And if you're in a case that's using some type of laser that requires recommended eye protection, you'll want to wear that, and also make sure that you have the provided eyewear for your patient as well. And if you're in a case that will be using x-ray, you'll want to make sure that you grab some lead. Being at the head of the bed, there will not always be an opportunity for you to distance yourself greater than 6 feet away from the x-ray, so you'll want to make sure that you put the lead on, including your thyroid shield. And there will probably be many people in the OR who do not wear lead. If you want lead and there's none in there, you can ask the x-ray techs or your circulator to get you lead, and they will make sure that you have it on before they do any x-raying. Same goes for the eye protection. There will be a lot of people in the OR that won't wear the recommended protection that you need. Don't be swayed by this and don't be intimidated. If you want to protect yourself, you can ask for whatever glasses that you need. The pre-induction sweep is the first sweep you're going to do. The purpose of a sweep is to double check you have everything you need at that point and it is safe to move forward. The pre-induction sweep is used to ensure you have everything you need to induce your patient. This includes appropriate medications, appropriate airway equipment, tape, suction that is connected and working. Patients can have copious secretions that may obstruct your view. They can also vomit, so you want to have suction on hand so you can quickly remove these secretions. A lot of providers go by no suction, no induction. You'll want to have your circuitry, which will help hold your circuit during intubation and to secure the circuit during surgery. Monitors with all cords available that you'll be utilizing. And make sure your sound is on for your alarms, your heart rate, and your SpO2. You'll not always be able to look up at your monitor during intubation because your main focus is on the airway. And just by listening, you'll be aware of your patient's status without having to look up. The frequency of the beeps will tell you the heart rate, and the tone will tell you your O2 saturation. You'll also want to have your train of 4, your IV pult, and your bear hugger. Some questions to keep in mind during preparation to help you select which drugs or airway equipment that you'll need is how stimulating or painful is this procedure. Think about the extent of the surgery and expected amount of pain that the patient will have during or after the procedure. This will help you plan accordingly. Will you need paralytic throughout the entire case? This will help you decide whether to use short versus long-acting neuromuscular blockers. And if you're only doing a MAC or placing an LMA, it's a good idea to have sucks available or drawn up just in case you need to emergently intubate that patient later on in the case. Does the patient have any allergies to medications? You'll want to keep this in mind when administering any medications, especially antibiotics. What are the patient's comorbidities? What's their malampati? Do you suspect that there'll be a difficult airway? How long is the procedure? All of these questions will help you plan what airway equipment you'll need available in the room or within an arm's reach. If there's an airway emergency, you want to be prepared. You don't want to be digging through the drawers or lack the equipment entirely. This would also be the time for you to make a ramp if needed for a patient who was larger or one that you suspected having a difficult airway. The next step is to provide patient safety. When transferring the patient from the stretcher to the OR bed, you want to make sure that both beds are low, that they're leveled with each other, and that they're locked. You as the anesthesia provider are in control of the move, so you'll check that everybody is ready and in position to transfer the patient, and then you'll count to initiate the transfer. As you assist patient transfer over to the OR bed, you'll want to protect the patient's head and neck alignment, especially when there's already sedation on board. And then you'll want to ensure that the IV stays secure and isn't pulled out during transport. Otherwise, you or another staff member will have to put one in. You'll want to position the patient's head at the top of the bed because it's the best position for intubating. The further the head is away, the more difficult it will be to maneuver how you need to intubate, and you'll put a strain on your back. During this whole process, you'll maintain communication with the patient, let them know what you're doing and how they can safely transfer over, and also ensure that they're in the middle of the bed and not sitting halfway on the stretcher. And once the patient's on the OR bed, you'll want to pull the anesthesia machine in close. You should be able to reach or take one step from where you're standing to reach your equipment, the bag, and your anesthetic gases. You now attach your patient to the monitors. The minimum required monitors are the pulse oximeter, blood pressure cuff, and ECG. While you're attaching the ECG leads, keep in mind that you're probably used to placing the leads while in front of the patient. Now you're above the patient, which makes it easy to mix up placement, so make sure that you're putting leads in the correct sides. And I try to place the blood pressure cuff first so that I can cycle while I'm attaching my other monitors. You will also place the mask on the patient's face. Utilization of mask straps can free up your hands a little bit and help get a good seal for pre-oxygenation, but it may not be needed if you have somebody assisting you with induction. And then once you have the patient connected, glance at your monitor, make sure that your vitals are actually coming across on the screen and that they're stable. When you put the face mask on the patient, ensure that your APO valve is open so that the patient can breathe easily in the mask. It's easy to forget to turn it back down after checking the circuit for leaks before your case. If you leave the APO valve closed, the patient would have to overcome pressure of 30 to 70 centimeters of water during exhalation, which is difficult. Have the patient tilt their chin up to help open the airway. Deliver 100% oxygen at greater than 6 liters per minute. And depending on the machine, it usually is already set at 8 liters per minute, and then personally, I just turn mine to 10 or 11 liters per minute. You'll pre-oxygenate the patient for 3 to 5 minutes, or to speed up the process of denitrogenation, you'll instruct the patient to take 4 to 8 vital capacity breaths. Your goal for pre-oxygenation is to achieve an end tidal O2 of 80 to 90%. And then adequate pre-oxygenation gives you more time during intubation before the patient desaturates, so it's very important. The purpose of your readiness sweep is to assess readiness to proceed to induction. You'll double check your vital signs. You'll verify that they are present across the screen and that they're within normal range. You'll open up your IV clamp so that your IV fluids are free flowing. The free flowing fluids will get your induction meds to your patient quickly. Again, double check that your APO valve is open so you're not obstructing the patient's spontaneous breathing, and check that your end tidal O2 is at least 80%. You'll want to raise or lower the bed to the appropriate height for you specifically. For optimum intubation positioning, sources recommend having the patient's head either at your xiphoid process or between the xiphoid process and the lower rib margin, which is about elbow height. Now it's time to administer your induction medications. You'll give your dose of fentanyl to help decrease the patient's sympathetic response to laryngoscopy, then your lidocaine to decrease the pain of the propofol injection, and then propofol to induce anesthesia. We encourage you to dose your propofol to the effect that it has on the patient. The patient may not always require the recommended calculated dose to achieve the desired effect, while other times they may require more. So look at your patient, assess the response, and go from there. You'll check for your lash reflex, And if no lash reflex is present, this is one indicator that the patient is asleep, and you can tape the eyes. We tape the eyes closed to protect them from injury. And if the patient's eyes don't completely close, you can gently shut them by manipulating the lateral canthus before taping. Once the patient is induced, you must confirm your ability to ventilate. Manipulate the patient's head in the sniffing position to align the oral, pharyngeal, and laryngeal axes. Using the EC hand configuration, create a tight mask seal and lift the patient's chin to further open the airway and assist with creating a seal to the mask. Advice I was given to help obtain a mask seal was using the fingers that are in the E position, using those fingers to pull the face into the mask. And then when you attempt to ventilate, pay attention to the patient. They shouldn't be reaching up to the mask. If they do, you'll want to give more propofol. While you're ventilating, you'll continue to make adjustments to the APL valve as needed to achieve adequate tidal volumes while also attempting to keep peak inspiratory pressures less than 20. And you're doing this to avoid going over the pressure of the lower esophageal sphincter and pushing air into the stomach. To confirm that you're delivering adequate ventilation, look at your patient. You should see fog in the mask and their chest should rise when you squeeze the bag. Then on your monitor, you should see an end-tidal CO2 waveform and adequate tidal volumes. And if you don't see these things, there are several things you can do. You can either, 1, insert an oral airway, or you can adjust your hand placement or the patient's head to obtain a better mask seal. And then positioning I find useful to me for obtaining a good mask seal and good ventilation is I turn the patient's head slightly to my right, which most of the time opens the airway up a little bit more, and then it uses gravity to help me get a better seal, and it's less work on my hand for me to press down on their face, and then it's easier to lift the face into the mask. Confirming your ability to ventilate is crucial because if you are unable to intubate, you know you can ventilate the patient and maintain gas exchange. Now that you know you're able to mask ventilate your patient, you can give your neuromuscular blockade. After administering your neuromuscular blocker, you will reestablish a mask seal, resume ventilation, and complete a mini sweep. You'll ventilate the patient while waiting for an adequate amount of time to pass for the neuromuscular blocker to take effect. Again, confirm that you have an end-tidal CO2 waveform and adjust your rate of ventilation based off the patient's end-tidal CO2 value. You'll also want to ensure that you are delivering adequate tidal volumes. Additionally, during this process, most providers will turn on the gas to keep the patient asleep just in case the induction medications start to wear off. If you're using succinylcholine, unless you administer a defasciculating dose of rocuronium, you'll usually see the patient fasciculate. Once the fasciculation stops, you may proceed with intubation. And if sux is used, many providers don't ventilate between administering the medication and then intubation. And then during an RSI, you wouldn't ventilate during that time either. If you're using rocuronium, it takes about 1 to 2 minutes to take effect. Therefore, you will ventilate for at least 90 seconds and then check a train of 4. If you have 1 to 2 twitches, proceed with intubation. If you have 3 to 4 twitches, you'll resume ventilation, then recheck your train of 4. As the paralytic sets in, you will feel the ventilation become easier as the muscles relax. Also during this time, glance at the vital signs, check that they're stable and that your SpO2 is at least 99 to 100%. Now it's time to intubate. If you turn the gas on while you are ventilating, turn it back off. You don't want to have the volatile anesthetic blowing into the OR and having everybody breathing in. So you'll scissor the mouth open, insert your blade on the right side of the mouth, and sweep to the tongue to the left. And when you're inserting the blade, be careful not to hit the teeth. Once the blade is in, ensure the lips are not pinched between the teeth and the blade. And then you're going to lift the blade forward and out, kind of towards the corner of the room. You're going to verbalize the airway structures to your preceptor. And then if using a Mac blade, you'll place the tip in the vallecula, and if using a Miller blade, you will lift up the epiglottis completely. Since your preceptor will not be able to see your view, make sure to verbalize the grade view you see so that they know where you are and suggest adjustments for you to make to improve your blade placement. Once you obtain a view, don't take your eyes off the cords. If you look away from the cords to look at the person handing you the tube, when you look back, you might have lost your view. All you need to do is reach your right hand up, ask for the endotracheal tube, and they'll place the tube in your hand. Try to hold the tube towards the upper portion, and then insert your ET tube. And then when inserting the tube, be careful not to scrape the cuff of the tube on the teeth because it may damage the cuff and require you to have to exchange the tube later on. You'll advance the cuff past the cords and then align the vocal cords between the marked black lines. And then you'll remove your blade carefully, again watching the teeth. You'll inflate your cuff, making sure to feel the balloon as you do so to avoid overinflation of the cuff. Then you'll connect your tube to the circuit. Next, you need to verify placement of the endotracheal tube. Manually ventilate the patient, verify that you have an end-tidal CO2 waveform, fog in the tube, chest rise, and peak pressures less than 30. A continuous end-tidal CO2 waveform is a strong indicator that the endotracheal tube is in the trachea. While continuing to give breaths or having the person assisting you give breaths, auscultate breath sounds bilaterally, and you are listening for breath sounds to be equal on each side. If breath sounds are only heard on one side, you may have placed the tube too deep and will need to pull the tube back with the goal of regaining bilateral breath sounds. If peak inspiratory pressures are around 30 to 40, again, the endotracheal tube is most likely in too deep and you may need to pull back. However, it is possible to have elevated pressures when dealing with patients that have significant lung compliance issues. Finally, note the depth of your tube. Keep in mind the calculations for approximate appropriate endotracheal tube depth, which is ET tube size times 3, or height in centimeters divided by 10 plus 5. It's important to note the depth so that when you go to tape the tube or check the tube throughout the case, you can see whether your endotracheal tube has migrated in or out. Once you confirm proper placement of the endotracheal tube and before taping the tube, you will need to place the patient on the ventilator and make machine adjustments. An easy way to remember this is vent, gas, flows. Flip the patient onto the vent, turn on your gas, reduce your flows to the appropriate amount. Now you can secure your endotracheal tube. You're going to tape it as close to the mouth as possible. This helps ensure the tube won't migrate. Keep in mind the type of surgery or what side that we'll be operating on. You want to tape the tube midline or to the side that will be out of the way. Make sure that you keep the tape off the lips because it can cause injury. And then there are multiple ways to tape the tube. Just find out which one you like the best. Next, you'll place the circuit in the holder. And keeping your circuit in the circuitry will prevent your endotracheal tube from coming out in the event that the circuit gets pulled. For your post-induction sweep, you'll check patient positioning and ensure proper head alignment. You'll slow down your IV fluids. You no longer need free-flowing fluids. You'll just adjust based off of vital signs or to give calculated fluid replacement. You'll check your vital signs for stability. If the patient is tachycardic, you may consider giving Esmolol, or if you think they're in pain, giving a little more fentanyl. And at this point, you'll want to be mindful of your MAC level. From induction until right before incision, the patient will not require a full MAC of gas. Usually a MAC of 0.7 to 0.8 is sufficient. If you run them at a higher MAC, you'll probably be combating hypotension from lack of stimulation until the surgeon finally makes the first incision. So if your patient does become hypotensive, you can decrease your MAC if appropriate, or you may just need to give a pressor. Then don't forget to apply your additional equipment. You'll apply your temperature monitoring, whether that's an esophageal temp probe or connecting the cord to the Foley temp. Or there's also a small temperature probe that can be placed in the patient's nose, or the one that is a sticker they put on the forehead. You'll put the bear hugger on, upper or lower, depending on the surgery, and then you'll wait to turn the bear hugger on until the final drape is up, which is the one that you'll clip to the poles. Then you'll also want to check your train of 4 and determine whether additional neuromuscular blockade is needed. Finally, you'll administer your additional medications. In a majority of cases, you'll give 2 grams of Ansef. If the patient's over 120 kilograms, you may give 3 grams, but be sure to check the patient's medication allergies before administration. If they have an allergy to an antibiotic ordered, verify with the surgeon which antibiotic they would like to replace it with. And as far as antiemetics, many providers give Decadron up front, then Zofran at the end of the case, and other providers give both at the beginning or both at the end. This choice is up to you. This is a list of our references, and thank you for listening. I have been sick today, so my nose has been all stuffy and my voice is very raspy, so I apologize that you had to listen to this whole PowerPoint presentation with me sounding like this.